Hi, good afternoon, everyone. My name is Jeanette O'Connor Shanley, and I am a contract manager with the New York State Department of Health, Office of Drug User Health Harm Reduction Unit. It's my pleasure to introduce our next presenter, Dr. Benjamin Hayes from OnPoint NYC. Dr. Hayes is a physician and an assistant professor in the Division of General Internal Medicine at Montefiore Medical Center and is a provider at the OnPoint Montefiore Drug User Health Hub Clinic in Harlem. Prior to medical training, Dr. Hayes worked in San Francisco as a social worker for people living with HIV and for people with substance use disorders. His current research includes studying and improving access to opioid use substance treatment and mail delivery harm reduction services. Thank you and welcome, Dr. Hayes.
Hi, thank you for that introduction. And it's a real honor to be here today. Some amazing, remarkable presentations. And it's sort of, leaves me kind of like, what else is there to add? We've heard a lot of really great information. So I'll try to provide a unique perspective on drug user harm reduction for healthcare providers. I go by he, him, his, and kind of throw in a perspective in the age of fentanyl here. So I have no conflicts of interest. Just a little bit about who I am. I am a physician now. I do primary care, and I had a primary care panel with Montefiore, and also we have this clinic with OnPoint, a collaborative clinic. But before that, I used to work as a social worker and volunteered for different harm reduction agencies as well. And most of my experience as a social worker was with people who were using substances, and that's how I kind of, you sort of learn that there's unequal treatment of people just based off of immense amount of stigma and discrimination. And so just a little bit about EPI. That's nothing that hasn't already been said, but we're in the middle of an overdose crisis in the US, and our practice in New York City, that's the same thing. And it has only been getting worse. You can see the rates of unintentional overdose deaths continue to skyrocket. And the neighborhoods that are most affected in New York City are those in the Bronx. Those ones in the green, you can see have the highest rates of unintentional overdose deaths per 100,000. The green are all the Bronx, and then East Harlem is the next little bit. And these reflect the numbers nationally. And you can see that the overdose deaths here, this gray line that sort of shoots right up, is synthetic opioids, primarily fentanyl. So this overdose crisis is primarily driven by synthetic opioids. And that's not just for people who are using opioids, but also people who are using stimulants. You can see here that national overdose deaths involving stimulants in these blue bars, and then stimulants in combination with synthetic opioids other than methadone, which is essentially fentanyl, is this yellow line that is really driving that increased rate. So, it's no secret here that we have a contaminated drug supply, that these deaths are being driven by fentanyl exposure. And fentanyl is in the supply of almost all illicit heroin, as well as common and illicit stimulants, cocaine and methamphetamine, and a lot of pills that people are buying off the street, thinking that they're buying benzodiazepines. And so there's a double risk here for people who are unintentionally using heroin / fentanyl and either cocaine or methamphetamine or both. So how do we respond to this crisis? Dan Ciccarone, who's a family medicine doctor who specializes in addiction at UCSF, has this quote, is firstly, don't panic. Stigma remains our biggest enemy. The idea being that our initial reaction of panic often reflects fear around addiction and stigma, and puts the onus of burden on people who use drugs. Harm reduction approach to healthcare is a better response here. Harm reduction is common to really all issues that we address in healthcare, but we're talking here specifically about harm reduction for people who use drugs. But on all harm reduction healthcare issues, we're talking about what is the setting that we're going to be applying our treatment in, what sort of counseling we can provide, what sort of treatment options can we provide, and also thinking about what is the community resilience factor. So I want to make the point that drugs are often a rational choice for people to deal with hardships, whether that's trauma, mental health, homelessness, sex work, but it's also a rational choice in terms of joy, spirituality, connection. We want to think about healing communities. There's a lot of breaking of the social, economic, and spiritual fabric of communities that are highly just impacted by addiction. Some of that is driven by racism, some of that's driven by economic disparities, and others. And then where are the public and safety partnerships that we can lean upon and build upon? So I'll speak from our perspective of working, collaborating with On Point NYC, which is a harm reduction agency in New York City that has a site in East Harlem and in Washington Heights. We are providers. I am a physician at Montefiore, and we've created this collaborative clinic with On Point for people who use drugs that are embedded within the harm reduction drop-in centers, essentially. So we have the one location in East Harlem and in Washington Heights, as I mentioned. You can see here the photos of the drop-in center. It's a safe, comfortable space for people to hang out in and just belong. There's staff who are kind, compassionate, and friendly and willing to help. And so people really feel like they have a real connection and a sense of belonging and ownership of the space. There's you can see down below, this is an overdose prevention center that's now located in both of these sites as well, sometimes called a safe injection facility, or in other places. And then you can see on the right, bottom right there, that's the clinic that we have, that's in the harm reduction agency. It's an attractive space that sort of confers a sense of like respect and dignity to our patients. So the clinic services, I think, is really important to speak about here. So in our clinic, we pride ourselves in offering low threshold medication for opioid use disorder. We provide an access point for reentry into primary care. We provide Hep C treatment on site. We provide PrEP treatment for HIV prevention. We do wound care. We can provide some acute care services. We'll help people reenter into HIV care. We offer counseling services, naloxone distribution. The harm reduction agency has case management, so we make like warm, direct handoffs with case management, although actually it usually goes the other way around, where they're handing off to us. And then we can help people with Medicaid enrollment. And really want to highlight that we establishing a supportive and healthy, non-stigmatizing clinical relationship with people who are using drugs who may have had poor experiences with the healthcare system in the past. In fact, I think you could speak with almost anyone who uses drugs that they've had a bad experience with healthcare in the past, which will color all their interactions in the future. And so we try to reset that relationship and provide them a space for healing in healthcare. Just to kind of provide a little schematic. So On Point Drop-In Center provides, we're one component of this larger wheel. We have our clinic. We're open for, actually now it should say 5 days a week. We use the Montefiore medical system, electronic medical records, Epic. Montefiore provides the lab supplies and the clinicians. And then On Point will actually hire their own clinician. We sort of collaborate in providing nurses and in registration staff. And then On Point has lots of other services, holistic health and acupuncture. They just have that nice, great hangout drop-in center, syringe distribution, overdose prevention center. They offer showers and laundry, which is just like, you can't say enough about the value of that. Case management, they have a kitchen and food, and then they have a really beautiful outdoor gazebo space with a garden. So, I think harm reduction, somebody mentioned in maybe the chat that it's really a way of being. It's not just a set of practices. And so there's a lot you can say about what harm reduction is. I'm going to zoom in on some of the principles that as doctors within this clinic, we've tried to embody and prioritize in our own practice. So humanism, pragmatism, individualism, autonomy, incrementalism, and accountability without termination. I'll go into a few of these specifically. I just put a photo there, the Chicago Recovery Alliance, because as somebody mentioned, Dan Big was such a huge force in our ability to be to spread harm reduction kind of above ground in a way. So humanism, this is a foundation for us. Providers value care for, respect, and dignify patients as individuals. The recognition that patients behave the way they do for very specific reasons, which is, often reasoned and logical, and that we want to be empowering to providers to understand how patients make decisions. So individualism, every person presents with their own needs and strengths. People present with the spectrums of health behaviors and therefore require a spectrum of different interventions. There's no one size fits all, obviously. Incrementalism, any positive change is a step towards a better health, and it can take years to accomplish. Providers should understand and plan for backward movements without judgment. Actually, I should reword that. I don't want to use the word backward. I feel like as healthcare providers, we sort of set what are good and bad goals in a way around drug use, but in fact, that's pretty subjective and presents opportunities for judgment. So maybe any movement around a patient's healthcare goals, and we do that without judgment. And then engaging in the healthcare system is key and saves lives. Stigma is a huge barrier for people who use drugs to get healthcare, and this is one of the reasons I think why, we use harm reduction within healthcare settings for almost everything, for people who have diabetes, for people who have hypertension, for people who are at risk for cancer. But we focus in on healthcare for people, or harm reduction for people who use drugs specifically, because there's such a huge stigma around people who use drugs that it hasn't seemed like they are deserving of the same level of healthcare and harm reduction that other people get. And we just want to make sure that we try to flip that script. So part of that is a work within ourselves and within our patients. And also we want to make sure we do that work within the healthcare settings that we're working on. And language is one of the most important first steps that we can take. So we want to be thoughtful of this when we speak with patients, with media, with colleagues, and in our notes, and teach and train our front desk staff, our phlebotomists, our nurses, our coaches, social workers, our fellow physicians and trainees. Change the Narrative is sort of an organization that's been working to do this within the media. And I think that most people are aware of this, but language around using the word abuser and addict is really a very stigmatizing term. We want to be very specific about what medications or substances people are using and why. Avoid the words clean or dirty, because that's really not informative and just full of stigma. And then lapse, relapse, slip. Those are sort of more morally laden terms. So you can use terms like resumed or experienced recurrence of symptoms, really based on what are the health goals of the patient in front of us. Are they trying to stop their substance? Are they trying to reduce their substance? And why? And how do we meet them there? Just as a sort of reminder about that, our conceptions around substance use and addiction are just historically laden in stigma and discrimination. And we're not at this place that we're at now by accident, that a lot of these things are intentionally constructed by society, by politicians, by companies, and people benefit and other people are harmed. This was a slide from Helena Hansen, people may be familiar with, and I just thought was kind of sums it up, that everyone's sort of targeted. And then we've paid a price as society. So that sort of stigma has led straight into policies that we passed, and criminalization around people who use substances and have substance use disorders, and how we police them. And this has had a devastating impact upon communities of color. You can see here, this is from the ACLU, that in 2003, people who are white constituted 7.8%, and people who are African American constituted more than 80% of defendants under the harsh federal crack cocaine laws, despite the fact that more than 66% of crack cocaine users in the United States were white or Hispanic at the time. And so, all right, so let's move on to, as healthcare providers, what are some of the best practices that we can implement from a harm reduction perspective? So one, ask patients about what their goals are for the visit. So often patients are concerned that the doctor is only going to focus on their drug use instead of taking care of what they might actually want. Avoid judgment, be concerned that they may be treated differently and prescribed medications differently because of drug use, and implement trauma-informed care skills. What is it that you don't know about this person who's sitting in front of you? Just assume that you're only getting a small window of their life, and so you want to be very respectful of how you might be triggering other people. And then treatment of substance use. Medication for opioid use disorder is a very effective harm reduction tool, as other people have mentioned already today. It provides stabilization, improvements in neuroadaptation, increases retention and treatment, increased functioning, decreases illicit opioid use and cravings, reduces all-cause mortality, reduces risk of HIV and Hep C transmission, and reduces criminal activity. Despite its effectiveness and sort of a push to make it more widely available, most people with opioid use disorder aren't getting medication for opioid use disorder. So over 2 million Americans with opioid use disorder, and really only 11% received MOUD. So we have a huge gap in need. And what we practice is low barrier or low threshold treatment for buprenorphine in our clinic. And for us, that means same-day evaluation and prescription for buprenorphine. We offer flexible drop-in treatment times and scheduling. We have no requirements for any services that people don't want to engage in, including counseling. We have a strong collaboration with the local pharmacy, and continued treatment for patients with ongoing drug use and treatment interruptions. I just speaking about that pharmacy for a moment, people may have had this experience where a lot of pharmacies will be, you see a patient, you come up with a treatment plan, you prescribe the medication, and you, excuse me, hey, Feifei, I'm on a meeting, you gotta step out, buddy. And okay, sorry, sorry for the interruption. And so we have a community pharmacy nearby that we've established a strong relationship with, and people feel very comfortable there with the pharmacist, which is really great. It's just a nice, safe space for them. So a little bit about flexibility, patient-centered approach to visit frequency and missed visits. We provide counseling and mental health treatment, but we do not require any of these things. And then we make it super easy for people to restart treatment if they've sort of stopped treatment or missed doses. Bupe is always safer than, I think the rationale is pretty clear. I think we've talked about that. And then, is low threshold treatment effective? Well, it's been going on now for several years at many different locations. These are just some examples in Baltimore, in Philadelphia, New Jersey, and Seattle, all presenting that it's feasible, and retention rates are actually pretty similar to those in other research studies of traditional care models. Some of the benefits of low threshold that have been published is that it overcomes delays in initiating buprenorphine without any negative effects on treatment retention. Flexibility in the requirements around prescribing medication for opioid use disorder increases access. And then being able to offer it in non-traditional settings like a syringe exchange program or a harm reduction program increases access for marginalized populations, such as people who are homeless and people who inject drugs. And then in our own clinic, we've looked at some of the data from February 5th, 2019 to October 9th, 2020. There were 118 patients who came through the clinic who got one or more prescriptions for buprenorphine. And our 30-day retention was 62%, 90-day retention was 43%, and 180-day retention was 31%. And the median percentage of days covered with a buprenorphine prescription during the first 180 days was 43%. So this is pretty good data. It's for a very high-risk group that's very transient, has a lot of competing priorities. A lot of our patients are marginally housed or homeless, living in the shelter. And so, being able to retain folks for this long is I think quite an achievement. And I think kind of speaks to that this is a really good practice method for certain groups of people in certain settings. I'll just mention really briefly that, how does this change in this age of fentanyl? I think people have probably heard that it can often be really challenging to start buprenorphine for people who are dependent upon fentanyl. Fentanyl seems to have this sort of lipophilic quality that makes it clear out of your system much longer. There's been a lot of reports that people starting buprenorphine with fentanyl in their system have a lot of precipitated withdrawal and have failed. Microdosing is a sort of prescription technique that's kind of been developed that might address this, where you start super low doses of the medication while you continue your full agonist opioid. And then every day you sort of incrementally increase the dosage until the point that you're on a high enough dose of the buprenorphine that you can just stop the full agonist opioid. This is like really common now in a lot of clinical settings, a lot of hospitals and clinics. There's been some literature published around this. And despite the fact that like almost all our patients have fentanyl in their urine or endorse using fentanyl intentionally, most of the patients we've seen have actually been fine with starting buprenorphine with our sort of a standard 2-day induction where they have to be abstinent for 12 to 24 hours and experience moderate withdrawal and then start. And most actually would just rather kind of get it done and over with. and there haven't been a lot of reports of precipitated withdrawal within our patient population. I don't really know why. I can't really explain that so well. Maybe it's just the geography. Maybe it's the composition of the drugs in our neighborhood. Maybe it's just kind of people's familiarity with Suboxone. There has been some sort of feedback from some folks that we did try microdosing with some people and it didn't work at all. And maybe a thought that, by the time they get to the 4th or 5th day, they sort of forget to take their Suboxone because they're still using heroin/fentanyl, and then they kind of lose their motivation. So maybe there's a window of motivation to start the buprenorphine and stop the heroin and fentanyl that we're missing. Also, I want clinicians to kind of sort of consider what are the treatment options for stimulant use disorder, because oftentimes we act as if there aren't any, but there certainly are. Cognitive behavioral therapy and contingency management are evidence-based. You might consider medication management. There's some limited evidence for this. There's new practice guidelines coming out from ASAM and AAP that are open to the public now that kind of talk about some of the evidence around medication treatment for cocaine use disorder and methamphetamine use disorder. These might be considered as part of harm reduction strategies. And then other drug use health. So test and treat infectious disease, test for HIV, Hep C, Hep A, Hep B, and treat hepatitis C. Obviously, I think a lot of people here on this call know that you can successfully treat people who are using drugs for hepatitis C. And then test and treat for other STIs, including syphilis. This just kind of demonstrates our success with treating Hep C in our clinic. So if you kind of look at the bars on the 3 bars on the right, so this is a sample of data from 2019 to 2022 that 35 people initiated treatment, 31 people completed the treatment, and 25 people had basically sustained negative hepatitis C viral load. So essentially 80% of those people were cured. 80% of the people who started treatment were cured, which is remarkable, and that those are really important numbers to acknowledge and celebrate. And then counseling around overdose prevention. So you certainly want to counsel around the fact that fentanyl is ubiquitous in all the drugs. Also, now we're talking about xylazine being very common. Try not to use alone or have a trusted friend or check in on you. There's this website, Never Use Alone, that we refer everybody to because almost all our patients prefer using alone. And so there's a hotline people can call and have somebody on the line with them while they're using. And so if they stop responding, they can call an emergency responder right away. prescribe or dispense naloxone, counsel about overdose prevention, refer people to harm reduction programs, and overdose prevention centers. Certainly aware that most people don't have the privilege of being able to work in a harm reduction program. So unfortunately, I'm aware that also there's not a lot of these spaces in other parts of the country outside of urban centers. And then provide resources for drug testing. So fentanyl test strips, xylazine test strips we heard about earlier. Overdose prevention centers, I'll mention briefly. These are facilities that allow people to consume and pre-obtain substances under the supervision of trained staff. The staff provides sterile injection equipment and other supplies. And these have been operating for a really long time and have been very successful. There's not been a single overdose fatality at any OPC worldwide. And then in November 2021, we had the two first officially sanctioned ones open up in the US and New York, in Harlem and Washington Heights. And these are photos of those spaces. And then since opening up, this is as of June 20th, 2023, there were over 3,000 participants who used the space over 78,000 times. The staff intervened on 945 overdose interventions, and there were 0 deaths. So that's amazing. Also, I'll move on. There's evidence for distribution of Narcan. Communities that higher, you can see on the orange and the green, those are communities that have higher rates of community distribution of Narcan with reduced opioid-related overdose deaths. Syringe access saves lives and reduces transmission of HIV and Hep C. You can prescribe these things. Here's some guidance around what to prescribe. You can also find local syringe service programs by going to thepointny.org. Also, there's mail delivery harm reduction supplies through what Next Distro. This is an amazing website, has a lot of resources, and you can get mail delivery harm reduction supplies, including sterile injection equipment and Narcan. Safer injection tips. I know we're running out of time, so I'm going to breeze through this, but I'll just say that you can counsel people on how to inject safely. Please do it. There's alternatives that people may prefer, including sniffing, booty bumping, and nasal sprays. And then so key points as takeaways: that medication for opioid use disorder is harm reduction. Please practice. Low threshold Bupe treatment increases access, embraces flexibility, challenges us providers to shift our thinking towards the patient priorities, and that we can provide health harm reduction services and counseling, and that SSPs and OPCs offer life-saving services. So refer your patients or continue to advocate with your local and state government officials about supporting opening these up. And that's it. Thank you so much.
Thank you, Dr. Hayes. That was an excellent presentation. I loved when you talked about resetting the relationship with the patient. So very important for so many of the clients that we see. I think in the interest of time, we'll move on.